the course of the nerves which are in the arm, and also we will talk about the arteries, about the subclavian, axillary, and brachial artery. Also, because the next class is packed with the new muscles, more than 20 muscles. So, because of this, also we will talk today about the cubital fossa, because this topic, together with this muscles of the palm, it would be information for one time. So.
Przepraszam najmocniej, ten monitor nie działa z jakiejś przyczyny.
Okay, well. Those muscles of the arm are just like, you know, the most famous muscle, the biceps. But biceps, remember, the expression biceps, triceps is the expression which is only used by the fitness instructor in the fitness club. I'm sorry, this TV is out of order.
Was
So
work.
only the screen, the big screen.
Was work before 5 minutes. It's easier to do it.
Maybe something will happen, but he told me that this something happened in the past, so there is some problem. Well guys, so what I said, if we use the anatomical term, we must use the full name of the muscle, the triceps brachii muscle, the biceps brachii muscle. If you give in the tests, any tests, the expression, only expression biceps, triceps, you obtain 0 points for such answer, because we have not only the biceps brachii muscle, also there is a biceps in the thigh, in the lower limb, and also there is a triceps suri muscle, which is in the palm. Well, first let's look at the kind of the cuff which surrounds the arm. This is a brachial fascia, or big fascia of the arm. It is a thin thin fibrous membrane which surrounds the muscles of the arm, and it is continuous with the fascia which covers the pectoralis major muscle, and also the fascia which forms the floor of the axilla. And next, the brachial fascia is continuous with the antebrachial fascia. What is important here in this brachial fascia is the fact that it sends two intermuscular septa towards the humerus. So this septum, the medial and the lateral septum, divides the whole arm into two compartments, the anterior compartment of arm and the posterior compartment of arm. What is important, this is the name, because also sometimes in the pin test also we mark the intermuscular septum. So we have the lateral intermuscular septum of arm and medial intermuscular septum of arm. Also you can use the expression the lateral intermuscular brachial septum or medial intermuscular brachial septum. So in the specimens we will try to show you these structures, because especially the medial septum is important for recognition of some structures. It's a good landmark to distinguish the brachialis muscle and the medial head of the triceps brachii muscle. So once again we have here a scheme through the section of the humerus. That this is a humerus we know because we have one separate bone. You know, there is a section for the humerus. And these green structures symbolize the position of the intermuscular septa. So, in the anterior compartment we have three muscles. Coracobrachialis, which is the smallest muscle, biceps brachii, which is the biggest muscle, and brachialis which is located the most close to the distal end of the humerus. In the posterior compartment, there is one huge muscle consisting of three heads. This is the triceps brachii muscle and the anconeus muscle, small muscle which is connected with the distal end of the humerus. The muscles in the anterior compartment and the posterior compartment of arm are very nice from the point of view of the innervation, because all muscles in the posterior aspect of the upper limb, including the posterior aspect of the arm, all of them are innervated by the radial nerve. And also here, even in this scheme, we can see the radial nerve. Why we know that this is a radial nerve? Because it runs just in the close relationship with the shaft of the humerus. The nerve of the anterior compartment of the arm is the musculocutaneous nerve. It will run together. It will run between the biceps brachii muscle and the brachialis muscle. Here, the nerve which is visible is the median nerve. Median nerve only passes through the arm. It doesn't innervate anything, and we can guess that this is a median nerve because it is in the close neighborhood with the brachial vessels, the brachial artery. So now let's look at the particular muscles. The first one, the smallest one, is the coracobrachialis muscle. In the name of this muscle are hidden the attachments, because the origin is in the coracoid process of scapula. The insertion is located on the humerus, on the medial third of medial aspect of the humerus. There isn't here any special structure, any bony element, which is a place of the insertion of the coracobrachialis, so this is such descriptive way of giving the distal attachment. But the proximal attachment is very, very characteristic. So that's the coracoid process of scapula. And guys, remember also, if you are asked to give the name of the insertion or origin of any muscle, if you give the name of the bony element, don't forget about the name of the bone, because without the name of the bone, the answer is not full, because we are not certain if the student knows that coracoid process is located in the scapula, so it must be added, the name of the bone, coracoid process of scapula, in this case. Now there's innervation. Innervation is easy, that's the musculocutaneous. And musculocutaneous has theoretically, because in our specimens it's not always visible because of the problem of the damage of specimen, but in some new specimens this relationship is visible. This characteristic fact that the trunk of the musculocutaneous nerve pierces the belly of the coracobrachialis. One of the characteristic features of the musculocutaneous nerve. It passes through the belly of the coracobrachialis muscle. Now let's look at the action of the coracobrachialis. Action is only performed in the glenohumeral joint, because the muscle doesn't run over the elbow joint, so it only makes any movements in the glenohumeral joint. So the movements, once again here, this relationship with the musculocutaneous nerve and coracobrachialis muscle. So main action is, because the muscle is located anteriorly to the glenohumeral joint, so its main action is flexion of the glenohumeral joint, and because it runs only from the scapula to the humerus, also it is responsible for the adduction of the glenohumeral joint. Because the muscle runs in the neighborhood of the capsule of glenohumeral joint, also it takes part in the protection of the glenohumeral joint against dislocation, especially the downward dislocation. Because it supports the head of the humerus in its glenoid cavity. From the point of view of the movements in the glenohumeral joint, this is once again flexion and adduction. Next muscle. Next muscle is the biceps brachiae muscle. Very important muscle once again, the muscle which is a synonym of the muscle. The muscle is called biceps because it consists of two parts, of two heads. It is the short head and the long head. Origin of the short head is located in the same place like the coracobrachialis muscle, and this is the coracoid process of scapula. Coracoid process of scapula. And the origin of the long head is located above the glenoid cavity, also in the scapula. Here we have the supraglenoid tubercle of scapula. And guys, here I suppose that you have this information in your famous and wonderful handouts, these materials which almost everybody has, that from the practical point of view, here we have one funny thing, that in the specimens the short head seems to be longer than the long head. Long head seems to be shorter than the short head, but this is an illusion, a false illusion, because the long head is covered by the muscle, including first of all the deltoid muscle, and it gives such situation that the initial part of the long head is covered by something different, and we see that the long head seems to be shorter than the short head. So, how to recognize these heads? Because the biceps brachiae is one of the basic muscles for the pin test. We must look at the places of the attachment. If we see that a tendon is attached to the coracoid process, so it's located more medially, it would be the short head of the biceps brachiae. The head which tendon has such course that it runs under the deltoid muscle, and we see that it will go above the shoulder joint, it would be the long head. So pay attention to this task, how to recognize the heads of the biceps brachiae. This is your task for today, for the practical part of the classes, because once again it's important. Majority of the students manage to learn this, and also the other students who also cannot learn these things. On the other hand, also you can remember, if one of the heads seems to be shorter than the second one, probably the shorter will be the long head. But this is, something what is it is not certain way. So the most certain way of recognition of the short and long head is looking at the places of the origin of the heads, places of the attachments. Next, guys, two heads of the biceps brachiae join to form one belly. And one thing more about the long head. The tendon of the long head runs through the glenohumeral joint. It is located inside the glenohumeral joint, and also its tendon runs in the groove which is between the greater tubercle of humerus and lesser tubercle of humerus. So in the intertubercular groove we have the position of the long tendon of the tendon of the long head of the biceps brachiae. And what I said, long and short head joins, and the whole muscle next will divide into two parts. This division is located inside the cubital fossa. The main tendon, strong tendon, is attached to the radius. In the radius we have the radial tuberosity. Radial tuberosity of radius is the place of attachment of the tendon of biceps brachiae muscle. The second part of the distal end of the biceps brachiae is a flat membrane, flat and thick membrane, which is called the bicipital aponeurosis. Bicipital aponeurosis covers the anterior aspect of the cubital fossa. Also, it covers the course of the brachial artery and the median nerve, and also the bicipital aponeurosis protects these structures. And bicipital aponeurosis is contiguous with the antebrachial fascia. Now there's here, it's something interesting. It's one of the example of the injury of the biceps brachiae muscle. Sometimes it may happen that one of the tendon, especially the long head of the biceps brachiae, can break. And we have such a bulge of the biceps brachiae in the arm. Of course, the muscle is painful and there is no strength in the flexion of the elbow joint. This syndrome is called the Popeye deformity or Popeye syndrome. So once again, this is a tearing of the long head of biceps brachiae. Why is it called the Popeye deformity? This is the name is coined in the name of the hero of the cartoon. You know, this Popeye sailor. So because he had such abnormal muscles, especially the biceps brachiae. So the Popeye deformity is the result of the rupture, the breaking of tendon of long head of the biceps brachiae muscle. So it may happen after too intensive exercises or because of an inflammatory process in the tendon of the long head of biceps brachiae. So sometimes it may happen. Well, next let's look at the main action of the biceps brachiae. In the glenohumeral joint, we have firstly the flexion of the glenohumeral joint. So as the flexors run both short head and long head. So in this movement, they cooperate, they are the synergistic muscles. But in the case of the abduction and abduction, short head and long head are the antagonistic muscles. Short head, similarly, just like the coracobrachialis muscle, so short head is responsible for abduction of the arm. Whereas the long head, because it runs above the glenohumeral joint when it pulls the arm, it is the muscle which is responsible for the abduction of the arm. Also, the long head supports the head of the humerus against the dislocation in the glenohumeral joint. Well, biceps brachiae runs above the elbow joint, so of course also it is active in the elbow joint. So biceps brachiae, I think that almost everybody knows because this exercise is very often done in the fitness gym, or if anyone takes any exercises at home. So flexion of the elbow joint. And biceps brachiae is one of three strong flexors together with the brachialis muscle and brachioradialis muscle. Flexion of the arm, flexion of the thumb in the elbow joint is performed by the biceps brachiae only in the supine position, in the supinated position of the thumb. Once again, supinated position is when the palm of the hand is directed anteriorly. So if anybody wants to have strong and, fabulous biceps brachiae muscle, so if you perform the exercise with, if we have, let's say that this is 5 kilo, yes, of the dumbbell. So we must do such movement, yes, when the palm of the hand is directed anteriorly. So that's the, 1,000 times. On this way, maybe we'll be successful. Also, guys, here, this symbol shows us that if we have the position of the palm, the biceps brachiae is here, is balanced, it contracts. If we have the position of the pronated palm, just like in this position, yes, so at this moment other muscles are active, but not the biceps. Biceps brachiae is flat here, so it means that it is not active. Also, the biceps brachiae is active in the radio-ulnar joints. In the moment in the radio-ulnar joint, it is the supination of the thumb and pronation of the thumb. When the ulnar joints proximal and distal, here the movements are up together. So in the radial ulnar joints, the biceps brachii up and the strong supinator. So it causes the lateral rotation of the thumb. Supination, its synonym is the lateral rotation of the thumb. And once again, biceps brachii flexes and supinates the thumb. Well, so supination. Supination is the movement when we perform the lateral rotation of the thumb. And also, let's say something about the bicipital aponeurosis. What I said, a bicipital aponeurosis has the role of the protective structure because it covers here the aspect of the elbow, here aspect of the cubital fossa. In the region of the cubital fossa, we have a lot of the superficial veins of the upper limb. This superficial veins of the upper limb in the region of the elbow fossa serve as the places of the intravenous injections, places of taking the samples of blood from the veins, etc. And if a nurse or a doctor or someone else performs the injection in this region, so it's important to introduce the needle only superficially, not too deep. So also when we say that brachial artery and median nerve, which is in the central part of the median, which is in the central part of the cubital fossa, are protected by the bicipital aponeurosis. This structure is relatively thick, so it has some protective function. And innervation of the biceps brachii is very easy to remember because musculocutaneous nerve, when it pierces the coracobrachialis muscle, next it goes in the direction of the biceps brachii muscle. Sorry. And here the musculocutaneous nerve runs between the biceps brachii and the brachialis muscle. So if we see a nerve which is between the muscles of the anterior compartment of the arm, it must be the musculocutaneous nerve. The last muscle in the anterior compartment is the brachialis muscle. Brachialis muscle is attached to the distal end of the humerus, and it covers here the anterior aspect of the distal part of the humerus, of the shaft of the humerus. And its insertion is very characteristic. This is the ulnar tuberosity and the colonoid process of ulna. So tuberosity of ulna or ulnar tuberosity, that's the same, and colonoid process of ulna. So it is in this bone in ulna. Biceps brachii is attached to the radius and brachialis muscle to the ulna. Its innervation is similar to the previous muscle, so it's musculocutaneous nerve, and because the muscle runs above the elbow joint, so its action is the flexion of the elbow joint, flexion of the thumb, and here in the case of the brachialis muscle, it is active either in supinated and pronated position of the thumb. So even if we have the pronated position of the thumb, the brachialis muscle is active. So although the brachialis is not visible, as you know, a part of the sculpture of our arm, but it gives the strength to the movement, to the upper limb. So it's important also. Well guys, now let's pass to the posterior compartment of the arm, and the first muscle here is the triceps brachii muscle. Triceps brachii consists of 3 heads, so that's the reason that it is called the triceps brachii. And this is long head, lateral head, and the medial head. Only the long head is attached to the scapula, lateral head and medial head are attached to the shaft of the humerus. And origin of the long head is located to the infraglenoid tubercle of scapula. Infraglenoid tubercle of scapula is located just under the glenoid cavity of scapula. So that's the origin of the long head of Chrysis brachiae. Lateral head and medial head are attached to the shaft of the humerus. And to describe the place of this attachment, we must repeat the position of the structure which is located on the posterior aspect of the humerus. Here we have the course of the radial groove. Radial groove will be the place of passage of the radial nerve. And the lateral head of the Chrysis brachiae is attached above the radial groove. So it is attached to the shaft of humerus above the radial groove. And medial head is located lower, and also it is attached to the posterior surface of humerus below the radial groove. Once again, if we magnify this fragment of the shaft of humerus, we can see this bare fragment of the bone. It's the radial groove. It will be the place of passage of the radial nerve, and above we have a place of attachment of all the lateral head of Chrysis brachiae, and below that's the place of attachment of the medial head of Chrysis brachiae muscle. Insertion of the whole muscle, so three heads join to form one belly, one bulk of the muscle, and its final tendon, its distal tendon, is attached to ulna, to the olecranum of ulna. Olecranum of ulna. Well guys, now the main action of the Chrysis brachiae muscle is such that long head supports the glenohumeral joint, and the long head is the only part of the Chrysis brachiae which is active in the glenohumeral joint, and it performs the extension. Generally say, muscles which are in the posterior compartment of the arm or posterior compartment of the thumb act as the extensors of the arm or extensors of the elbow joint. Also, long head, because of its course, when it pulls the arm, it causes the abduction of the arm, so it pulls the arm towards the trunk. And what I said, also it protects the glenohumeral joint against dislocation. In the elbow joint, the Chrysis brachiae muscle is only, it acts as the extensor. And this is the sheath extensor of the elbow joint. So if we want to, of course, the main force which causes the extension of the elbow joint is the force of gravitation. So if we want to have a strong Chrysis brachiae, we must perform the extension of the elbow joint against resistance. So there are some special exercises which are focused on the Chrysis brachiae muscle. Well guys, and innervation of the Chrysis brachiae muscle is from the nerve which runs in the neighborhood of it. So we can guess, because the heads of the Chrysis brachiae muscle surrounds the radial groove, so we may guess that the nerve responsible for its innervation is the radial nerve. And what is very important from the point of view of the function of radial nerve is the fact that radial nerve gives off the branches to the long and lateral head before it enters the radial groove. That's important because the radial nerve, the most often place of the injury of radial nerve is the radial groove. If the radial nerve is injured in the radial groove, the lateral head and the long head of the Chrysis brachiae muscle are still active, so they are not paralyzed because they receive the branches from the healthy, from the not injured part of the radial nerve. So that's the reason that in the case of the radial nerve palsy, the extension of the elbow joint and extension of the arm is not disturbed significantly. Branches to the medial head arise in the radial groove, but if two heads of the thoracic brachiae muscle are active, so the extension of the elbow joint is not disturbed significantly, what I said. And now let's look at the radial groove. Radial groove, or in other words, canal of the radial nerve. In English terminology, it's more often called the radial groove. Radial groove is located on posterior aspect of the arm, and its boundaries are the following. This is the superiorly, we have the lateral head of the thoracic brachiae muscle. Inferiorly, this radial groove is bounded by the medial head of the thoracic brachiae. Posteriorly, it is covered by the long head of the thoracic brachiae. Here, the long head is pulled away to expose the radial groove, but normally it covers the posterior aspect of the radial groove and posterior aspect of the radial nerve. And what is the most important here in this neighborhood, in these boundaries, is the anterior boundary. This is the shaft of humerus, and on this shaft of humerus we have the radial groove. So this bony hard background for the course of the radial nerve is shift for the function of the radial nerve. So generally saying, please remember, if there is any place in the course of the nerve when the nerve runs in the vicinity of the bone, it's a dangerous place for the nerve because it may cause the injury, especially when the nerve is pressed towards the bony background. Usually it causes the lack of blood supply of the nerve and the injury of the nerve. The contents of the radial nerve, of the radial groove, is first of all the radial nerve. But here there is one surprise for students, especially who are not detailed and they try to guess something, but they have not enough knowledge. At the first glance, we should say that in the radial groove should run radial artery, but unfortunately radial artery is not present here. It's a huge mistake when someone gives the answer that here there is the radial artery. Why, in a moment we will say. Together with the radial nerve run the deep artery of arm, which is the branch of the brachial artery. So this is a companion of the radial artery, of the radial nerve, here in the radial groove. Also we have here the deep veins of arm, which have the same name. So the deep veins of arm, which are the tributaries of the brachial vein. And why this radial nerve canal, this radial groove, is so important from the clinical point of view? Because radial nerve is very often, this is the most often place of the injury of the radial nerve. And if we have the injury of the radial nerve in such a high section of its course, all distal muscles which are normally innervated by the radial nerve will be paralyzed, especially all muscles of the posterior compartment of the front. So next time we will talk about them. Muscles in the posterior compartment of the thumb are responsible of the extension of the wrist and extension of the digits. And they are the only extensors of the wrist and digits. So when we have the pulse of the radial nerve, the effect is the inability of the extension of the wrist joint and extension of the digits. So it's a huge impairment, a huge problem for the patient. So such movement like extension of the wrist and extension of the digits is what I said is very weak, is not present. And that's the way how we examine the strength of the muscles in the posterior compartment of the thumb. And examining the strength of the muscles, also we examine the integrity of the function of the nerve. So what I say, when we have the proximal injury of the radial nerve, so injury of the radial nerve at the level of the radial groove, the symptom is called the wrist drop, because we have a drop of the hand. in the wrist joint. So let's start wrist drop. Here, the shift problem is not the lack of the sensation in the skin, but the inability of the extension of the wrist in the wrist joint. Popper mentioned that the triceps brachii is rather not paralyzed in the proximal pulse of the radial nerve because the radial nerve gives off the branches to the long head and lateral head before it enters the radial groove. The most often reasons of the injury of radial nerve first is very easy to guess. So it's a fracture of the shaft of humerus. Here we have the X-ray which shows us the fracture of the humerus, of the shaft of humerus. Here, just like when we have the skin, so such injury, fracture of the shaft of humerus, and first of all, this is important. And the result is what I said, wrist drop. Also, guys, even without a fracture of the humerus, the radial nerve can be injured. So it happens very often in the clinical practice. If any heavy object will be put on the arm, for example, this heavy object can be our head. When we use the arm instead of the pillow, and when we have our head on our arm, especially during deep sleep, the result sometimes can be, for example, such situation, can be the palsy of the radial nerve, because this deep sleep very often happens after overuse of alcohol. This type of the injury of radial nerve was called the Saturday night palsy. So it's also the type of the injury of the radial nerve. So guys, that's a good tip for you. Not only, of course, first of all, don't overuse the alcohol. That's the most important, because it's it's harmful for your nerves and also for your brain. That's the most important problem. But also the problem, which is maybe not known to majority of people, if someone sleeps in this way, in the morning it may wake up with dropped hand, with the wrist drop. And believe me that this type of the palsy may stay for whole life. It should be recovered, but nobody knows when, because it is very individual. This recovery of the peripheral nerves is very, very individual, and the consequences can be very, very unpleasant, because such hand is completely useless. A huge impairment. Well, guys, the next muscle, the last muscle for today, which we will describe, is the anconeus muscle. Anconeus muscle is the small muscle which is extended between the lateral epicondyle of the humerus and the olecranum of ulna. So also this is a muscle. It's innervated by the radial nerve. Theoretically, it can act as the extensor of elbow joint, but it's a weak extensor. Its main function is the stabilization of the elbow joint. Right, anconeus. And now, guys, let's pass to this description of the area in the place of the transition of the arm into the forearm. On the anterior aspect of the elbow area, we have the region which is called the cubital fossa. And guys, to describe the boundaries of the cubital fossa, we must look at two muscles of the palm. Laterally, there is a muscle which is located in lateral aspect. This is the brachioradialis, would be this one. And this, which is symbolized by the letters PP, it would be the pronator teres muscle. So next time, on Tuesday, we will describe these muscles in details. Boundaries of the cubital fossa. Lateral boundary is the brachioradialis, and the medial boundary is the pronator teres muscle. So these are the muscles of the palm. So here, these are these two muscles. floor of the cubital fossa is formed by the brachialis muscle, which is located under the biceps brachiae muscle. And also in the floor of the cubital fossa we have the supinator muscle. Supinator muscle is also the muscle of the thumb. It belongs to the posterior compartment of the thumb. So these two muscles are in the floor of the cubital fossa. Roof is the cubital fascia, which is strengthened by the bicipital aponeurosis. Its contents, one more thing, from superior direction to the cubital fossa descends the tendon of the biceps brachiae muscle. The contents, what I said, it's a tendon of the biceps brachiae muscle, and also we have here two nerves and very important artery. From the nerves here we have the median nerve which lies in the central part of the cubital fossa. It will lie medially to the tendon of the biceps brachiae muscle, and median nerve runs together with the brachial artery. Next median nerve will go between the heads of the pronator teres muscle. Radial nerve is located in the lateral part of the cubital fossa, and here in the cubital fossa we have very important stage of the course of radial nerve. Radial nerve divides here into the deep branch and superficial branch. Next course of these branches we will discuss next time. Next elements in the cubital fossa are the vessels. Brachial artery, which descends to the cubital fossa, divides here into its main branches. So it's the radial artery and ulnar artery. Radial artery is more superficial and it goes towards the lateral aspect of the thumb, and ulnar artery will run deeper and it will be located more medially in the thumb. So guys, for today, for the practical part of the classes, you must know how to recognize the structures in the cubital fossa. So you should recognize here also the main arteries of thumb. The radial artery, its origin here in the cubital fossa and ulnar artery, and also from the radial nerve, the deep branch and superficial branch. Together with the brachial artery, we run the brachial veins, and also we may have here the position of some cubital lymph nodes which are present. Superficially, like I said, cubital fossa is covered with the cubital fascia strengthened by the bicipital aponeurosis, and here we have the course of the superficial veins. So at this moment, let's stay at this expression because the next classes, next lecture about the vascular system of the thumb and hand. Also we will have the information about the veins, main veins in the upper limb. So at this moment let's only do. Also we have here the course of the cutaneous nerve, also they are present here. And now guys, to summarize the muscles which are active in the glenohumeral joint, let's look at the examples of the muscles active in the particular pairs of movements. So the first pair of movements in the glenohumeral joint is the pair flexion extension. So the flexors, guys, even if we don't know by heart this list, if we know the position of the muscle, if we can imagine how it looks, the contraction of the muscle, we can guess the function of the muscle. So the flexors will be these muscles which are located anteriorly to the glenohumeral joint. So it will be the pectoralis major muscle, sheath muscle, anterior part of the deltoid, and also from the current classes coracobrachialis and long head of the short head of the biceps brachiae. Also the long head. I don't know why is it only the short head. The whole biceps brachiae, but especially the short head, because it lies anteriorly to the glenohumeral joint. Extension. So these muscles which are attached from the posterior direction to the humerus. So it would be posterior part of the deltoid, latissimus dorsi, and teres major, because these are, from the point of view, they act like one unit. And finally, the long head of the triceps brachii. Next, guys, the next pair of movements, abduction and abduction. So,
Can we go back for one picture? First?
guys, haven't you seen the house? Sweet, yes. Well, so, abduction, abductors will be these muscles which will run above the shoulder joint. So it's the chief abductor, the strongest is the deltoid, especially its middle part. Also in the abduction participate the supraspinatus muscles. So these are the most important abductors. Additionally, here we have the muscle which we mentioned today, long head of biceps brachii, because it lies above the shoulder joint. Abductions will be these muscles which will pull the arm towards the thorax. So it's first of all the pectoralis major, strong abductor, latissimus dorsi and teres major, subscapularis muscle, infraspinatus also, and the teres minor. It's when they say the alphabet, you like hamsters and how do they call, my goodness, rabbits, yes. Lecture about the upper limb. Guys, lateral and medial rotation. So, medial rotation, when we embrace something, you know, so, just like the little rabbit, yes. So, it's the pectoralis major, yes, because it does the humerus medially. Next, latissimus dorsi and teres major and subscapularis muscle, because they pull the humerus and they perform the medial rotation. Medial rotation or internal rotation, that's the same. Also the anterior part of the deltoid and the teres major muscle. Lateral rotation is very easy because these are three muscles which belong to the rotator cuff muscles. Infraspinatus, teres minor, and the posterior part of the deltoid. No, maybe deltoid is not the rotator cuff muscle, but also it's the muscle which performs the lateral rotation. Well, guys, and now also we must mention, because next time we will have no time for this, let's look at the the elbow joint. So the flexion and extension, flexion. Four muscles, three are mentioned here. So it's the biceps brachii, strong flexor, but active only in the supine position, in the supinated position. Brachialis muscle. Also the muscle which is mentioned here is the brachioradialis. It's one of the muscles of the farm, also strong, and also it acts in both positions of the farm. And the muscle which also I mentioned today, pronator teres. And finally, the extension of the elbow joint is the triceps brachii and the anconeus. Now guys, let's look at a short review of the nerves which are present in the arm. For this time today we will analyze the cause of the musculocutaneous nerve, because this is a nerve which is responsible for the innervation of the muscles in the arm. anterior compartment, and also why is it called musculocutaneous? Because it also innervates the lateral aspect of the farm. Remember, not the lateral aspect of arm, but lateral aspect of the farm. Origin of the musculocutaneous is the lateral cord of the brachial plexus. In the lateral cord of the brachial plexus, we have the components, we have the elements of the superior trunk of the brachial plexus, which consists mainly of the 5th cervical and 6th cervical spinal nerves. Why is it important? It's important, these spinal nerves, because in the last lecture we will talk about the palsy, about the injury of the whole brachial plexus. And if we know which spinal nerves are in the particular peripheral nerves, it will be much easier to understand why we have the difference between the superior palsy of the brachial nerve and the inferior palsy of the brachial plexus, of the brachial plexus. But it's for the future. In a week we will talk about it as a kind of the summary of the whole innervation of the upper limb. Force of the musculocutaneous we partially described. It pierces the coracobrachialis muscle. Next, it runs between the biceps brachii muscle and the brachialis muscle. And finally, of course, it supplies these three muscles of the anterior compartment of the arm. And finally, it terminates, its terminal branch is a sensory branch which is called the lateral cutaneous antebrachial nerve. Also, you can call it lateral cutaneous nerve of the thumb. So you can choose this version of the name which you prefer. So the range of innervation, once again, coracobrachialis, so muscles of anterior compartment of the arm, and the skin in the lateral surface of the forearm, once again, forearm, not the arm. Symptoms of palsy, the injury of the trunk of musculocutaneous nerve maybe is not very often, because of course is protected here by the muscular elements, by the soft elements. If there is the problem with the musculocutaneous nerve, rather it's caused by the injury of the superior part of the brachial plexus. But if we have such symptom of the pulse of musculocutaneous nerve, remember guys, if we have injury of the peripheral nerves, the chief problem is the atrophy of the muscles which are innervated by the given nerve. So here we have the atrophy, the diminishing of the bulk of the coracobrachialis, biceps brachii, and brachialis muscle. Also, we have the impairment of the flexion and the flexion of the elbow joint and supination of the thumb. Supination of the thumb is weakened because the biceps brachii is a strong supinator, but these movements are not totally, how to say it, they are present, but they are weakened. Why they are present? Because we have other muscles which are connected with the flexion of the elbow joint. Some muscles of the thumb, especially the brachioradialis, is innervated by the radial nerve, and so that's the reason that the flexion of the elbow joint is present, although it is weakened. And loss of sensation in the skin on lateral aspect of the thumb may appear. Next guys, let's look at the brachial section of the medial nerve, ulnar nerve, and the radial nerve. Medial nerve, its origin is from two roots, lateral root and medial root. Because the medial nerve comes from two cords of the brachial plexus, medial and lateral. It will consist almost all spinal nerves which form the brachial plexus. So because it's a huge nerve, C6, C7, C8, and T1 nerves. The course in the arm from the axilla, it runs together with the brachial artery along the biceps brachii. On the medial aspect of the biceps brachii, there is a so-called medial bicipital group, especially people who have, strong musculature when they contract when they move, such famous movement. Here on the medial aspect of the arm is visible such bicipital groove, and it's a place of passage of the brachial artery and medial nerve. If we palpate here the pulse of the brachial artery, it means that we will find the position of the medial nerve also. Next, the medial nerve descends to the cubital fossa. Here it is covered by the bicipital aponeurosis. It protects the nerve against injury. And next, it will pass to the anterior compartment of the palm. So the next stages of its course we will discuss next time. As you can see here at the scheme of the range of innervation of the medial nerve, we should notice that medial nerve innervates no muscles in the arm. No branches. In the arm it gives no branches. The main destination of the medial nerve is the anterior compartment of the palm, and also some nerves, some muscles in the hand. Well, so the next details about its course and the symptoms of the palsy we will discuss next time. Next, the ulnar nerve in the brachial section. The ulnar nerve is a branch of the medial part of the brachial plexus. Medial part of the brachial plexus is the continuation of the inferior trunk of the brachial plexus, and in the inferior trunk we have spinal nerve C8 and Q1, 8 cervical and 1st thoracic. The course, firstly, it runs together with the brachial artery and medial nerve, so they run together. Next, in the distal part of the arm, the ulnar nerve pierces the medial intermuscular septum, and it passes to the posterior compartment of the arm. Here, it runs along the medial head of the triceps brachii, and next we have a shift stage of its course, because it passes posteriorly to the medial epicondyle of humerus. And this is one of the most dangerous places of the passage for the ulnar nerve, because we have here very close the bony element, and also the ulnar nerve is covered here only by the skin, so it's very easy to injure it here. Next, it enters the palm, and it passes between the heads of the flexor carpi ulnaris muscle, and the next stages of its course we will discuss next times. Branch of the motor innervation. Again, in arm we have no branches of the ulnar nerve. Also, in the anterior compartment, here only guys, you don't need to, today only this is information, because next time we will analyze this range of innervation in details when you learn the names of the muscles in the palm. Here only I would like to say that ulnar nerve is responsible here for innervation of one muscle and a half of the flexor digitorum profundus. So we may say 1.5 muscle is innervated in the anterior compartment of palm by the ulnar nerve. The main area of the innervation by the ulnar nerve is the hand. So majority of the muscles in the hand, the so-called short muscles of the hand, are innervated by the ulnar nerve. And the same, which muscles are innervated precisely by the ulnar nerve, we will learn in a week when we talk about the hand. Range of the sensory innervation is very characteristic. Even now we can guess this range of innervation, because skin of the hand, especially skin of the little finger, the fifth finger, and the medial half of the ring finger are innervated by the ulnar nerve. So when we have here, for example, in a moment I will show you this syndrome. When we have here, for example, the compression of the ulnar nerve behind the medial epicondyle of humerus, very often we can feel the numbness, pins and needles sensation in the area of the little finger, or the numbness here. Well guys, now let's look at the potential places of compression or injury of the ulnar nerve. So what we guessed many times, and we mentioned many times, the most dangerous place of passage is the posterior aspect of the medial epicondyle of humerus. If we have here the injury and a serious injury of the ulnar nerve, the result will be the so-called claw hand. It means that it would be the inability of the extension of the fingers in the interphalangeal joints, together with the atrophy of the short muscles of hand. Here again, there's the image of the hand and the consequences of the palsy of the ulnar nerve. We will discuss next, especially during the last lecture from upper limb. Here today, only I would like to show you the the general view of this problem. But the claw hand, such very severe deformity of the hand, will appear if the ulnar nerve is injured and it lasts longer, this state. The most often problem which we have with the ulnar nerve is called the student's elbow. It's a kind of the neuropathy of ulnar nerve, especially if we press the elbows to any hard background, just like here the surface of the table or surface of the armchair or something of this kind. It causes the compression of the ulnar nerve to the hard ground, and the most often problem is the sensation, unpleasant sensation, which is called in medicine the pins and needles and numbness sensation in the region of the skin, which is suffered by ulnar nerve. It means region of the little finger and the ring finger. If it is, this atrophy, if this neuropathy stays longer, through months, it may lead to the atrophy of interosseous muscles and to the claw hand, to the appearance of the claw hand, deformity of the hand. Well, so guys, especially before exams, avoid such position, because it's harmful for our nerves. And guys, finally the radial nerve. Once again, its origin, it's posterior caudal brachial plexus, because posterior caudal brachial plexus is formed by posterior divisions of three chunks of brachial plexus. Radial nerve contains the fibers of all spinal nerves which form the brachial plexus. The radial nerve from axilla runs on posterior aspect of the humerus, and it runs in the posterior compartment of the arm. It runs here between the heads of the triceps brachii muscle, and its structure which runs together is the deep artery of arm. Also here on the arm, the radial nerve gives rise to two cutaneous nerves. This is the posterior antebrachial cutaneous nerve and also the inferior lateral brachial nerve. So in a moment, especially this inferior lateral brachial nerve will be important for today because it takes part in the innervation of the lateral aspect of the arm. Next, radial nerve pierces the lateral intermuscular septum of arm and it passes to the cubital fossa. In the cubital fossa, it divides into two branches, superficial branch and deep branch. So, from the level of the cubital fossa, we don't talk about the radial nerve. We are talking about the superficial branch of radial nerve and deep branch of radial nerve. Well, we will continue the description of the radial nerve next time when we talk about the muscles of the thumb, because of course radial nerve here, what I mentioned, is responsible for the innervation of the triceps brachii muscle and the encomius, but its main destination is the posterior compartment of the thumb. And about the consequences of the palsy and the potential place of injury, I have mentioned it previously. Now, to summarize the innervation of the skin in the arm, Skin in the arm, the same it will be in the skin of the palm, is divided into three surfaces: lateral surface, medial surface, and posterior surface. So it's a schematic division. The best way to learn the innervation of the skin in the limbs is looking at the picture in the atlas. So it's a mistake if we try to learn it by heart. Medial surface is innervated from two sources. This is the medial cutaneous nerve of arm, or medial cutaneous brachial nerve. This is a branch of the medial frontal brachial plexus. The second source, very important from the clinical point of view, these are the intercostal brachial nerve. Intercostal brachial nerve is a branch which arises from the second intercostal nerve, and the intercostal brachial nerves innervate the skin in the region of the axilla. These branches are important, especially in the surgery of breast, in the cancer of breast. Very often it happens that the patients can feel an unpleasant sensation, pains, for example, in the region of the axilla because of the irritation of the nerves, intercostal brachial nerves. Lateral surface of arm has the innervation from two sources. Upper part, superior lateral aspect, is innervated by the superior lateral cutaneous nerve of arm, which arises from the axillary nerve. Inferior part of the lateral aspect is innervated by the inferior lateral cutaneous nerve of arm from the radial nerve. And posterior aspect is innervated by the posterior cutaneous nerve of arm from radial nerve. Okay, well guys, and now let's change the object of the analysis. Now we will look at the arteries of the upper limb. So we will look at the subclavian artery, axillary artery, and brachial artery. If you look at the notice that truly saying this is one vessel because here only this vessel changes the name. In the proximal part it is called the subclavian artery, in the middle part it is called the axillary artery, in the distal part it is called the brachial artery. Here only the brachial artery divides into two forking elements, the radial artery and the ulnar artery. So today we will analyze subclavian, axillary and brachial arteries. You should remember, guys, of course, that the origin of subclavian artery is different in right side and left side. The right subclavian artery is a branch of the brachiocephalic trunk, which arises as a first branch of the arch of the aorta. Left subclavian artery is the third branch of the aortic arch. Subclavian artery, so we may say that the right subclavian artery is shorter, left one is longer a bit. General course, it passes, it goes, the subclavian arteries go up, and next they leave the thorax. They are present in the supraclavicular region of the neck, and here they arches above the apex of the lung and the cupula of the lung, of the pleura, cupula of the pleura. Next, the subclavian artery leaves the supraclavicular region of the neck together with the brachial plexus, and they will run in the gap which is between the first rib and the clavicle. This position is located between two scalene muscles, the anterior scalene muscle and middle scalene muscle, and this is the posterior space of the scalene muscle of the cervicoaxillary canal. Last time also I mentioned that to find the brachial plexus, position of the brachial plexus, for example, we can try to find the pulse of the subclavian artery. Palpation of this pulse is taken above the middle part of the clavicle. Next, the subclavian artery enters the axilla and it changes the name. from the subclavian artery into the axillary artery in the place of crossing of this huge vessel, arterial vessel, with the external border of the first rib. So the region of the vasculature of the subclavian artery is huge because it is brain, spinal cord, neck, thorax, and upper limb. To the upper limb, so it runs the main trunk of the subclavian artery. To the rest of the regions which are mentioned here, will run the particular branches of the subclavian artery. And now let's look at them. For the descriptive purposes, the subclavian artery is divided into three sections. This landmark, which divides the whole course of the subclavian artery, is the anterior scalene muscle. So the branches which arise from the proximally to the anterior scalene muscle, they arise from the first section. Second section is located behind the anterior scalene muscle, and the third section is located distally to the anterior scalene muscle. And now let's look at these branches. First two branches are from the first section. The first branch is the vertebral artery. You should remember, guys, because it's not possible to discuss these arteries in details, I would like to recall you, to remind you that this artery goes up and is responsible for the blood supply of spinal cord. Its main destination is the brain, because the vertebral artery enters the foramen magnum of skull, and it takes part in the blood supply of the brain. Brainstem, it means the medulla oblongate, pons, mesencephalon, and also occipital lobes of the brain. Also, internal ear. Next artery should be remembered by you, because we talked about it during the thorax. That's the internal thoracic artery, which descends along the sternum, and it takes part in the blood supply of intercostal spaces, also the breast, and generally saying also some organs of thorax which are located closer to the anterior wall of the thorax. Next branch, thyrocervical trunk. Thyrocervical trunk gives rise to three branches. Inferior thyroid artery takes part in the blood supply of the thyroid gland, and also trachea and esophagus. Next branches, suprascapular artery. It runs together with the suprascapular nerve and supplies the supraspinatus and infraspinatus muscle of the scapula. And transverse cervical artery supplies posterior triangle of the neck. So once again, the thyrocervical trunk. Next, we have the costocervical trunk. Also, artery which should be remembered by you, superior or supreme intercostal artery supplies two posterior intercostal arteries for the first and second intercostal spaces. And deep cervical artery supplies deep muscles of the neck. And the last artery, branch of the third section, is the dorsal scapular artery, which will descend together with the dorsal scapular nerve, and it supplies the muscles which are attached to the medial border of scapula, so especially the levator scapulae and rhomboids muscle. This is the subclavian artery. Axillary artery, the next section. Its origin, so it's the continuation of the subclavian artery. The place of changing the name is the border of the first rib. Its general course, it runs in the axilla. Here it is surrounded by the cords of the brachial plexus. Partially, its anterior aspect is covered by the pectoralis minor muscle. Pectoralis minor muscle is important from the point of view of the description of the branches of axillary artery. And continuation of the axillary artery is the brachial artery. And again, the place of changing the name is the moment when the axillary artery crosses the inferior border of the teres major muscle. Similar to the subclavian artery, we have in the axillary artery also the muscle which forms a kind of the landmark which divides the whole axillary artery into the three sections. This muscle, this is the pectoralis minor muscle. So we have here three parts, three sections of the axillary artery. And now let's look at the branches. Again, because here the picture, is the best way is to look in the atlas in these elements, because maybe here on the screen it's not easy to identify the particular branches. So the branches of the first section. So it's the superior thoracic artery, and the superior thoracic artery takes part in the blood supply of the serratus anterior upper intercostal spaces. Next, very characteristic branch is from the second section, so it arises behind the pectoralis minor muscle. It's the thoracoacromial artery. Thoracoacromial artery gives rise to four branches: acromial, deltoid, pectoral, and clavicular. And they supply corresponding muscles and areas. For example, deltoid branch of the thoracoacromial artery will supply the deltoid muscle. Pectoral branch will supply the pectoralis minor, pectoralis major muscle. Next branch, lateral thoracic artery, should be known to you because it descends on the lateral aspect of the thorax, and it takes part in the supply, blood supply of the lateral aspect of the thorax. So serratus anterior muscle and breast. It gives rise to the lateral mammary branches to the breast, to the lateral quadrants of the breast. Next, guys. From the third section, we have here a rise of the subscapular artery. Subscapular artery divides into two branches: circumflex scapular artery and thoracodorsal artery. Thoracodorsal artery runs together with the thoracodorsal nerve, and they supply, first of all, the latissimus dorsi muscle, so it's easy to remember. Circumflex scapular artery will leave the axilla through the triangular space, and it takes part in the blood supply of the region of the scapula, especially the infraspinatus muscle and teres major muscle. And finally, the last branches of the axillary artery are the circumflex humeral arteries, anterior and posterior. They surround the neck, surgical neck of the humerus, and especially the posterior circumflex humeral artery. It runs together with the axillary nerve. They together leave the axilla via the quadrangular space. Also, this artery, because it runs together with the axillary nerve, it takes part in the blood supply of the deltoid muscle. Deltoid muscle is a huge muscle, so it needs more than one artery. Now, guys, let's look at the brachial artery. Brachial artery is a continuation of the axillary artery, and it descends in the arm together with the medial nerve along the medial surface of the biceps brachiae muscle. It enters the cubital fossa, and here it divides into the radial artery and ulnar artery. In the arm, brachial artery gives rise one strong branch. It is called the deep artery of arm. It also can be called the deep brachial artery or the profunda brachiae artery. So three versions of the name. You can choose this one which you prefer. Deep artery of arm will run together with the radial nerve in the radial groove. And this is a sheath artery for the posterior compartment of arm. Also, the deep artery of arm gives rise to two collateral arteries, radial collateral artery and medial collateral artery. So here these are two branches. These collateral arteries take part in the information of the arterial network, which is located on the posterior aspect of the elbow joint. And the last branches. Let's come back to the brachial artery, to the main trunk. Before it enters the cubital fossa, it gives rise to two collateral arteries, the superior ulnar collateral artery and inferior ulnar collateral artery. Superior ulnar collateral artery will run together with the ulnar nerve behind the medial epicondyle of humerus. Collateral arteries, radial collateral artery, middle collateral artery, and ulnar collateral arteries, once again, they take part in the formation of the arterial network, arterial anastomosis around the elbow. So why these anastomoses are important? Because, for example, if we have, let's say here, ligation of the brachial artery in the distal part of the brachial artery, the blood supply of the distal part of the upper limb can be sustained thanks to the blood flow via this arterial anastomosis, so the small vessels which are located in the region of the elbow. So it is possible to keep the blood supply of the distal part of the upper limb. The same, guys, is the possibility of the collateral circulation around the scapula. So here it's called the scapular arcade or arterial anastomosis, arterial network around scapula. So these connections of the arterial vessels give the possibility of collateral circulation for upper limb when the direct blood flow via the main arteries is not possible. It may happen, for example, in the case of the occlusion, so the blockage of the main trunk of artery, or in the case of if we have the lacerated artery, or if the arteries are ligated in the course of any surgical procedures. So, arterial anastomosis around the scapula are formed by the following branches. First of all, the dorsal scapular artery, a branch of the subclavian artery, you can see it here, and the subscapular artery, once again, dorsal scapular artery and the suprascapular artery. So they are the branches of the subclavian artery. Second source is from the axillary artery. This is the subscapular artery, which gives rise to the circumflex scapular artery. So these branches join together. And what I said, if we have, for example, the ligation of the subclavian artery after the place of arise of the dorsal scapular artery, the blood flow here through the subclavian artery and axillary artery is not possible. But it will be possible thanks to this collateral route. So via the dorsal scapular artery and next the circumflex scapular artery to the subscapular artery and axillary artery. So it is still possible. There are only some rules in such. It is important for future surgeons to remember that it is not possible to ligate the axillary artery or brachial artery in the places in which we want to do it. Because, for example, ligation of axillary artery is possible only proximally to the subscapular artery. If it is done lower, this alternative route will be not possible. So we will have no blood flow towards the distal part of the upper limb. The same in the case of the brachial artery. Here the chief artery for formation of this collateral circulation is the deep artery of arm. So the ligation of the brachial artery is possible only distally to the deep artery of arm. If it is done proximally, this collateral circulation will be not possible. Thus, now let's look at some possibilities of the visualization of the blood system of arteries in upper limb. So here our famous arteriography of the arch of aorta. So let's remember, first branch, brachiocephalic trunk, dividing to the right subclavian artery and right common carotid artery. Left common carotid artery is here, and left subclavian artery is the third branch of the aortic arch. The same, guys, here, please, you can also analyze this radiograph in your textbook. We have here subclavian artery, here we have the axillary artery, and the particular branches. So if you look carefully here, we can notice, for example, maybe the branches are not huge. Lateral thoracic artery, branch of the axillary artery here. Subscapular artery, even dividing into the circumflex scapular artery and thoracodorsal artery. Next, guys, here very characteristic to the surgical neck. The circumflex scapular artery, usually the posterior one is stronger, so it is broader one. And here, to the shaft of the humerus will go the deep artery of arm, so this is the most characteristic. Well, guys, so also the last thing, let's don't forget about the places of possibilities of taking the pulse in the upper limb. Here some possibilities are shown, but the one is not shown. So subclavian artery, but last time I showed you this possibility. This is the point which lies above the middle point of the clavicle. So we take the pulse of the subclavian artery. Axillary artery, maybe the pulse is rarely taken. Medial bicipital groove is a place of taking the pulse of the brachial artery. Also, the brachial artery can be palpated in the cubital fossa. Although here the pulse is not felt, but this is a traditional and conventional place of taking the blood pressure. So if you have this possibility of taking examination of blood pressure, so the stethoscope is up to the region of the cubital fossa. But the next is distal places we will discuss later. So guys, when we say that the current classes is the easy one, comparing to the next classes, so if I can appeal to everybody next time, when we have the muscles of the forearm, so prepare theoretically at home. So learn the names of the muscles, because it will be not possible to recognize any of the muscle if you don't name the names of them in advance. And now, before you go, I would like to show you a fragment of the film about the arteries of the upper limb, because the state of the arteries of our upper limb are not this wonderful thing.
This lecture is much shorter than I expected. I thought you would spend like 3 hours with the turtle speed. Are you coming to PE today? Because usually you're late if you come.
I'm not coming, Papa.
Let's review what we've seen. Vein, artery,